Dear students, today's topic is on pleurae. So the pleura are the serous sacs which cover the lungs. So before beginning with the pleura, it's better to have an introduction regarding thoracic cavity. So thoracic cavity, it is otherwise called chest cavity, which is enclosed by sternum anteriorly. So anteriorly you can view the sternum. Sternum is otherwise called as breastbone and ribs on each side. So there are ribs on each side, and posteriorly the thoracic cavity is bounded by the vertebral column. So these are the structures bounded to the thorax. So let's talk about the superior thoracic and inferior thoracic opening. So the superior thoracic aperture is the junction between the structures of the root of the neck and contents of thoracic cavity. So here I am drawing the outline. So this is the superior thoracic aperture, and it measures approximately 5 centimeters anterior-posteriorly. So anterior-posterior diameter is approximately 5 centimeters and transverse diameter is around 10 centimeters. So if you see the shape of the superior thoracic aperture, it is almost like kidney shape and it is bounded by manubrium sterni. So here is the manubrium. So the upper boundary of the manubrium forms the anterior boundary, and on each side it is bounded by the first rib. So this is the first rib, is present laterally on each side, and first thoracic vertebra posteriorly. So these are the boundaries of superior thoracic aperture. Let's talk about the inferior thoracic aperture. Inferior thoracic aperture is a bony circle of sternum in front, that is the xiphoid process. So the lower tip of the sternum is called as the xiphoid process. Xiphoid process of the sternum, and posteriorly T12 vertebra. So this is 12th rib. 12th rib articulates with the T12 vertebra. So posteriorly it is bounded by T12 vertebra, and on each side posteriorly 12th rib, and anterolaterally it is formed by the costal margins. So you can see here, this is the costal margins on each side. So the costal margins are formed by 7th to 10th ribs, which all unite with each other to form a costal margin. So from 7th to 10th ribs. 11th and 12th are floating ribs. So each lateral compartment, so if you see inside the thoracic cavity, each lateral compartment, it is occupied by lungs. So here these purple colored structures are lungs, and these lungs are enclosed in a serous sac which is called as pleural cavity. So this pleural cavity or this pleural space contains a thin layer of fluid which is called as pleural fluid. The middle compartment, so the rest of the middle compartment which is between the lungs, so I am just drawing the boundaries. So this part, the middle part, is called as mediastinum, and which contains all the thoracic structures except the lungs and pleura. So such as heart with its pericardium, great vessels that leave or enter the heart, thymus, structures that traverse the thorax to enter the abdomen and which are passing from the neck to the abdomen or from the abdomen to the neck, such as esophagus, vagus nerves, phrenic nerves and thoracic ducts. So these are the contents of mediastinum. So present topic is on pleura and pleural cavity. So we shall begin with the pleural cavities first. Pleura is a thin serous membrane around the lungs. So here the lungs are removed to showing, this is the image showing only the pleura which is present within the thoracic cavity, and one side the ribs are removed to expose the pleura. So this blue colored structure is the pleura, which is a thin serous membrane surrounds the lungs, and that consists of two layers, parietal pleura and visceral pleura. So here in this image we can appreciate the pleura is removed to expose the lungs on one side. So right lung is exposed and this is pleura, and the ribs are cut here to expose the pleura and the lungs. So here is the schematic picture showing the two layers of pleura. So the purple colored ones are the lungs, right and left lungs, covered by a double layered serous sac. This green color, the outer lining, is the parietal pleura, and deeper one, which is along with the lungs, is the visceral layer, visceral pleura. So each lung you can see here, it is invested by and it is enclosed by the serous sac, and where the two layers we see they are continuous with each other at the hilum. So here we can see they are continuous with each other surrounding the hilum. So the two layers here are the visceral pleura and parietal pleura. Visceral pleura, you can appreciate it invests all the surfaces of the lungs, forming a shiny outer surface, whereas the parietal pleura lines the pulmonary cavity. It is along the chest wall, that is the pulmonary cavity, that is it is along the thoracic wall and the mediastinum. So the potential space between the visceral and the parietal pleura is called as pleural cavity or pleural space. So the cavity you can see here between these two layers. So it is the pleural cavity, which is a potential space between the visceral and parietal pleura. And this tiny space between the two layers filled with the small amount of serous fluid known as pleural fluid. So this contains pleural fluid. The outer layer is called as parietal pleura and the inner layer is called as visceral pleura. And the visceral pleura is continuous with the parietal pleura at the root of the lung. So here is the root of the lung. We can see the parietal pleura reflects to form visceral. So both are reflecting with each other around the root of the lung. So the parietal and the visceral layers are separated from each other by slit-like potential space, which is called as pleural cavity filled with the pleural fluid. And pleural cavity is normally filled with the thin film of tissue fluid which lubricates the adjoining surfaces of the pleura and allows them to move on each other without friction. So that is the function of this pleural fluid which is present in the pleural cavity normally. So the two layers becomes continuous with each other at the root of the lung. So here the root of the lung consisting the structures entering and leaving the lung. So here it is just shown the bronchus. So right side there are two, epipartial and hypartial. Left side it is the principal bronchus, and along with the bronchus there are pulmonary arteries, pulmonary veins, and sympathetic plexus, bronchial vessels, and also lymphatics. So there are many more structures which are along with the bronchus entering inside the lung and leaving the lung. Altogether it is called as the root of the lung. So these structures enter and leave the lung at the hilum of the lung. So this point is called as hilum. So we see this parietal and visceral pleura, they get reflected at the hilum of the lung. So talking about the pleura now pleura, it is like peritoneum. It is a serous membrane and it is lined by flattened epithelium. So if you take histologically, it is lined by simple squamous epithelium which is called as mesothelium. The lining epithelium secretes a watery lubricant which is called as serous fluid. So between the two layers, the thin serous fluid is present, right? So that is secreted by mesothelium. Pleura, we know now it has got the visceral layer which is called visceral pleura and outer parietal layer, parietal pleura, and the moistened space between the two layers called as pleural cavity which is filled with the pleural fluid. So let's talk about the visceral pleura alone. Visceral pleura, it is along with the lungs. So the other name for the visceral pleura is pulmonary pleura. So visceral pleura is otherwise called as pulmonary pleura, and visceral pleura, if we see, it is like completely covers the lungs surface except at the hilum. So except at this part, the visceral pleura completely it covers the lung. So it is called pulmonary pleura. So it along the attachment of a ligament. So here this is the image of the visceral pleura. So we can see the parietal pleura gets reflected to form the visceral pleura at the root of the lung. So here is the image of the root of the lung. These are the structures forming the root of the lung which go inside and come out of the lung at the hilum of the lung. So here along the attachment of the pulmonary ligaments. So the visceral pleura, it completely covers the surface of the lung, we know it now, except at the hilum. So here is the image of the hilum exposing the root of the lung. So this is the root of the lung where structures go in and come out of the lung. And along the attachment of pulmonary ligament. So this sleeve like structure which is below the root of the lung is called as pulmonary ligament. So along the attachment of the pulmonary ligament, the visceral pleura gets reflected to form the parietal pleura, and it also extends into the depths of the fissures. Like if we see the visceral layer as it is along with the lungs, and the lungs has got the fissures which divides the lungs into lobes, and this visceral layer it invests along the fissures. So it is along with the depths of the fissures of the lungs, and it is firmly adherent to the lung surface and cannot be separated from it, that it cannot be peeled off easily. It is attached to the lung always. Next, about the parietal pleura. So here is the image. The green colored structure is the parietal pleura. So parietal pleura is thicker than the visceral pleura and lines the walls of the pulmonary cavity. And let's see the subdivisions of parietal pleura. For the purpose of description, we can divide the parietal pleura into we can subdivide the parietal pleura according to the surface which it lines. So the area where it covers the costa, that is the ribs, it lines the inner surface of the thoracic cavity of the ribs, it is called as costal pleura. So this is the costal pleura. And the parietal pleura which is along the inferior surface of the lungs related to the diaphragm is called as diaphragmatic pleura. And the pleura which is on the medial surface of the lungs forming the boundary of mediastinum, lateral boundaries of the mediastinum are called as mediastinal pleura. So this is mediastinal, and the part of the parietal pleura which is in the neck, which extends beyond the first rib, is called as cervical pleura. So this is So we can divide into 4 parts. So talking about the costal pleura first, it lines the inner surface of the thoracic wall and it consists of ribs. The thoracic wall consists of ribs, costal cartilages and intercostal spaces, to which it is loosely attached by a thin layer of loose areolar tissue called as endothoracic fascia. So the gap between the parietal pleura and the thoracic wall consists of a loose areolar tissue which is called as endothoracic fascia. So in living beings, the endothoracic fascia is easily separable from the thoracic wall. So that is about the costal pleura. Next, about the diaphragmatic pleura. Diaphragmatic pleura, it covers the superior surface of the diaphragm. So below on each side the lung rests over the diaphragms. So that is the dome of the diaphragm. So just above the superior surface of the diaphragmatic pleura is present. In quiet respiration, the costal and diaphragmatic pleura are in opposition to each other and before the inferior border of the lungs. So the costal and diaphragmatic. So this is the costal and this is diaphragmatic. They are in opposition with each other during quiet respiration. Next, moving on to the mediastinal pleura. Mediastinal pleura, as the name suggests, it lines the corresponding surface of the mediastinum and forms its lateral boundaries. It is reflected as a handcuff over the root of the lung. So we can see here the parietal pleura gets reflected near the root of the lung. So we can see here it gets reflected around the root of the lung and continues with the visceral pleura, forming the pulmonary ligament. So it forms a sleeve over the root of the lung, forming pulmonary ligament. Okay, let's talk about the cervical pleura. So this is the last part of the parietal pleura and it is a dome-shaped parietal pleura which extends into the root of the neck. So you can see here this dome-shaped structures which extends into the root of the neck beyond the first rib are called as cervical pleura, which is present on each side. And it approximately around 1 inch above the medial end of the clavicle. 1 inch means 2.5 centimeters. This is the medial end of the clavicle. So it is around 1 inch above the medial end of the clavicle and 2 inches above the first costal cartilage. So this is the first costal cartilage. So 2 inches above the first costal cartilage. It is also called as, so this cervical pleura of parietal pleura, which is also called as the cupola. Cupola means dome-like and it covers the apex of the lungs. Therefore, it is of utmost care should be taken while penetrating this area with the anesthetic needle. And this parietal pleura, it is further covered, preventing the cervical pleura extending into the neck. So this is further covered by a membrane called as suprapleural membrane or 𝐒𝐮𝐻𝐿's fascia, which is otherwise called as 𝐒𝐮𝐻𝐿's fascia. Covers the cervical pleura, preventing the lungs expanding beyond the 2.5 centimeters into the neck. So next, about the relations of the cervical pleura. Anteriorly, the cervical pleura, it is related to subclavian artery, scalenus anterior muscle, and posteriorly it is related to the neck of the first rib. Laterally, it is related to scalenus medius muscle and medially it is related to the great vessels of the neck. So these are the relations of the cervical pleura. Next, moving on to the pulmonary ligament. So we completed with the visceral and the parietal pleura and different subdivisions of parietal pleura. So moving on to this pulmonary ligament, the pleura that surrounds the root of the neck, which serves to attach the lung to the mediastinum, means this is the root of the neck which connects the mediastinum to the lungs, and it extends downwards as a fold, which is called as pulmonary ligament. So the pleura, parietal pleura, it forms a double layered vertical fold which is called as pulmonary ligament. So it is a double layered serosal sheath. So pulmonary ligament is a double layered serosal sheath. So the parietal pleura forms the pulmonary ligament, and the two layered vertical fold of the mediastinal pleura which extends along the mediastinal surface of the each lung from the hilum till the base of the diaphragm. So this downward it is up till the base of the diaphragm. So it is like a vertical fold of a mediastinal pleura. And if you see the shape, it is a free falciform. Falciform means sickle-like. So it appears to be like a free falciform border, and it is not a true ligament, but rather it is the reflection of the mediastinal pleura. So it is not a true ligament, it is the reflection of mediastinal parietal pleura below the root of the lung, on each side where the pleura is thrown outside as a loose fold. So you can see it as loose fold, and this fold is filled with the loose areolar tissue. So here this part, so this is loose areolar tissue is present, and it also contains lymphatics and also some nerve plexus which supply the lung. So the pulmonary ligament provides the potential space for the expansion of the lung tissue. So because it is like a empty loose areolar tissue, it provides the space for the expansion of the lungs, and it also provides the dead space for the expansion of pulmonary veins during venous return. So this is the pulmonary veins. So during venous return, the pulmonary veins has to be expanded. So this potential space which is present within the pulmonary ligament, it allows the pulmonary veins to expand, providing a dead space for the pulmonary veins during venous return. So that is about the pulmonary ligament. Okay, next move on to the recesses of pleura. The site where the visceral pleura is reflecting as the parietal pleura. So that sites, the space between them is greatly expanded, and these expanded regions of pleural cavity are called as pleural recesses. So these pleural recesses serve as a reserve space of the pleural cavity for the lungs to expand. So normally they are potential spaces. They allow the lungs to expand during deep inspiration. So let's discuss what are the pleural recesses present. The first one is the costodiaphragmatic recess. There are two costodiaphragmatic recesses, right and left costodiaphragmatic recess. As the name suggests, it between the costa means the ribs, and diaphragm means it is between the diaphragmatic surface. So it is located inferiorly between the costal and diaphragmatic pleura. So this is one. This is the other costodiaphragmatic recess. So this costodiaphragmatic recess, it is located inferiorly between the costal and diaphragmatic pleura, and it is slit-like space formed by the reflection of costal and diaphragmatic parietal pleura. So this is the costal pleura and this is the diaphragmatic pleura. So you can see it gets reflected to enclose this costodiaphragmatic recess. So it is located inferiorly between the costal and diaphragmatic pleura, and it allows the expansion of the lungs inferiorly during inspiration. So excess fluid within the pleural cavity, suppose if there is excess fluid within the pleural cavity, it accumulates in the costodiaphragmatic recess that is, and costodiaphragmatic angle. So if you take a PO radiograph, that is the posterior anterior radiograph of chest X-ray in erect posture, this costodiaphragmatic recess is prominently observed with the filled fluid if there is any collection of fluid in the pleural cavity. Vertically, it measures about 5 centimeters. So here vertical measurement is around 5 centimeters, and it lies opposite to 8th to 10th ribs, approximately from 8th to 10th ribs. Along the mid-axillary line. So here it is. So this is 8th, 9th and 10th. So 3 ribs along the mid-axillary line. The costodiaphragmatic recesses are the most dependent parts of the pleural cavity. Hence, the fluid of any pleural effusion, the first area of sites of collection of the fluid is costodiaphragmatic recesses. The next recesses are the costomediastinal recesses. There are also 2 right and left costomediastinal recesses which are present on the medial side. So this is the costomediastinal recess, it is located anteriorly between the costal and the mediastinal pleura and lies between the sternum and the costal cartilages. So here it is between the sternum, the center breastbone is the sternum, and the margin is formed by the costal cartilages. So this margin. So it is between the sternum and the costal cartilages. Costomediastinal recess is a slit-like spaces between the costal and mediastinal parietal pleura. So during inspiration, the anterior borders of both lungs expand and enter the right and left costomediastinal recesses. So in addition, the lingula of the left lung expands and enters into the left costomediastinal recess. So this is the lingula of left lung. This is the right lung. This is left lung. So the lingula of the left lung during inspiration, it enters into the left costomediastinal recess. The right costomediastinal recess is possibly occupied by the anterior margin of the right lung and even during quiet breathing. So the left costomediastinal recess is large due to the presence of cardiac notch in the left lung. So you can appreciate it is quite larger area compared to the right because it presents a cardiac notch on the left side. The left lung presents a cardiac notch on the left side. And next we shall move on to right and left retroesophageal recess. So next, after completing about costodiaphragmatic and costomediastinal recess, we shall move on to right and left retroesophageal recess. As the name suggests, retro means behind. So these recesses are present behind the esophagus. So here is a cross section taken along the lungs. So the middle space is the mediastinum. So this is the retroesophageal recess. They are formed by the reflection of mediastinal pleura behind the esophagus. So here is the esophagus in the mediastinum. We can see, I'll just draw a line over it. We can see the mediastinal recess reflects over the lungs on each side. So this reflection is called as retroesophageal recess. It is called as retroesophageal recess. So each recess is thought to be occupied by a part of lung, and it also contributes to retrocardiac recess. So same thing within the mediastinum. Behind the heart it is called retrocardiac recess. So the space in the radiographs are appreciated in the chest radiographs X-rays, and inferior cardiac recess. Inferior cardiac recess is the small recess of the right pleural sac which sometimes extends beneath the inferior vena cava, which is called as inferior cardiac recess. Let's move on to the clinical importance of these recesses. And radiological appearance of pleural effusion means if there is an excess amount of fluid in the pleural cavity, it is called as pleural effusion. So when a small quantity of fluid collects in the costo-diaphragmatic recess, so here is the yellow colored structure is the collection of fluid in So we can see the collection of fluid in the costo-diaphragmatic recess, which is called as pleural effusion. So the angle is the costo-diaphragmatic angle. So normal side I'll show, this is the angle. So this is the normal. So normal costo-diaphragmatic angle, whereas this angle is reduced in the radiograph. You can see here the shadow appears like this. So there is no costo-diaphragmatic angle. So the angle is lost. So it gets obliterated, the angle gets obliterated, and we can see a widening of the angle, and it is seen in the radio-opaque shadow with the fluid line in the X-ray chest. And this may be the first indication of pleural effusion. Therefore, recesses of the pleura are examined routinely in the chest radiographs. The costo-diaphragmatic recess can be entered through 9th and 10th intercostal space. So here is the 9th, 10th intercostal space. So the needle is passed between 9th and 10th intercostal space. So without penetrating the lung in the patient and in quiet breathing, just it lies opposite to between the 8th and 10th ribs. Let's see the sites of extension of the pleura beyond the thoracic cage. There are 5 sites where the pleura extend beyond the thoracic cage. The sites are like on either side of the root of the lung as the domes of the pleura. In the right xiphisternal angle or infrasternal angle, in the junction between of the lateral margin of the xiphisternum with the right costal margin, that is the second side, and third on either side of the costovertebral angle. So on each side, both the sides of the costovertebral angle, the pleura can be punctured inadvertently at these sites during surgical procedures. So that is how you should know the sites where the pleura extend beyond their spaces. Next, about the nerve supply of pleura. So before going into the nerve supply, I just want to add on a note on the development of the pleura. So the pleura develops like this. This is the trachea, which is developing trachea, where we can see lung buds on each side. This is the pleural cavity. And the outer, this is, so you can see here the lung buds invaginates into the pleural cavity like a punching inside the balloon. So we can see the lungs starts growing here, and this is the parietal pleura, and the inner layer forms visceral pleura. So the parietal, the outer pleura, it is developmentally from somatopleuric mesoderm. We know the lateral plate mesoderm. If you see the lateral plate mesoderm, it divides into 2 parts, somatopleuric mesoderm and splanchnopleural mesoderm. So parietal layer develops from somatopleuric mesoderm. Whereas the visceral layer develops from splanchnopleural mesoderm. So this is the visceral layer and this is parietal layer. So the somatopleuric lateral plate mesoderm because it is along with the somatopleuric, it is supplied by the somatic nerves. So parietal pleura is supplied by somatic nerves, and hence it is pain sensitive because it has got pain receptors, so it is pain sensitive. So if we see this parietal pleura, we know we divided into costal part, diaphragmatic part, mediastinal part and cervical part. So costal part and peripheral part of the diaphragmatic pleura is supplied by intercostal nerves, whereas the mediastinal pleura means the medially present, the mediastinal pleura and the central part of the diaphragmatic pleura is supplied by the phrenic nerve, which supplies the diaphragm. And visceral pleura, coming to the inner lining, visceral pleura, we know it develops from splanchnopluric mesoderm, splanchnopluric layer of lateral plate mesoderm. Hence, it is supplied by autonomic nerves. Autonomic means sympathetic nerves. So, from T2 to T5. So, T2 to T5, they supply the visceral pleura, sympathetic. And they are insensitive to pain because they doesn't have pain receptors in the visceral pleura. So, next about the referred pain of pleura. The pain of the central diaphragmatic pleura means the central part of the diaphragmatic pleura and the mediastinal pleura, it is referred to the neck and the shoulder through phrenic nerves, because the phrenic nerve root value is C3, C4 and C5. The root value is C3, C4, C5. So because of these, the skin at these sides has the segmental innervation which supplies. So shoulder tip, it is supplied by C3, C4, C5, same spinal segments. That is the reason if there is any irritation of mediastinal pleura and central part of diaphragmatic pleura, because this part of pleura is supplied by the phrenic nerve, so the referred pain will be referred to the shoulder tip because of same spinal segment innervation. And blood supply of the parietal pleura. So we have completed with the nerve supply. Next we shall move on to the blood supply. So blood supply of the parietal pleura is same as that of the thoracic wall, and blood supply of the visceral pleura, that is the pulmonary pleura, is same as that of the lungs. So let's see some differences between the parietal and visceral pleura. So note down some differences. Visceral pleura development, it is developed from splanchnopluric lateral plate mesoderm. Parietal pleura develops from somatopleuric lateral plate mesoderm. And if we see the location, visceral pleura lines along the surface. It is intimately attaches to the surface of the lung, whereas the parietal pleura lines the thoracic wall and the mediastinum. Blood supply for the visceral pleura, they are same as the lungs, so they are supplied by bronchial arteries. Whereas the parietal pleura, the blood supply, arterial supply, are supplied by internal thoracic artery, superior phrenic artery, posterior intercostal arteries and superior intercostal arteries, which supply the thoracic wall also. Venous drainage of the visceral pleura, they drain into pulmonary veins along with the lungs, whereas the venous drainage of the parietal pleura, they drain into systemic veins along with the thoracic wall. Nerve supply of visceral pleura, we know it is pain insensitive, so they are supplied by autonomic nerves. And whereas parietal pleura nerve supply is by somatic nerves and they are pain sensitive. So to be specific, autonomic nerve supply to visceral pleura is T1 to T5 segments and parasympathetic is by vagus. Whereas the parietal pleura, it is supplied by intercostal nerves from T2 to T5 segments which supply the peripheral costal pleura, and the central part, mediastinal and central part of the diaphragmatic pleura is supplied by the phrenic nerve. So lastly, about some more clinical importance, infection of the pleura, that is inflammation of the pleura, is termed as pleurisy or pleuritis. It is called pleuritis or pleurisy, which is nothing but the inflammation involving the visceral pleura. Present no pain because they are pain insensitive, they doesn't show any pain. Whereas parietal pleuritis, if there is any inflammation in the parietal pleura, it is associated with sharp local pain and referred pain felt in the thoracic wall where the intercostal nerves supply, and the root of the neck where the phrenic nerve supply, that is C3, C4, C5. And clinically, parietal pleuras presents as pain which is aggravated by the respiratory movement. So when the person is during inspiring and expiring, the pain gets aggravated and the pain radiates to the thoracic and abdominal walls. It is commonly caused due to pulmonary tuberculosis, so TB lungs. The pleural surface becomes rough due to the accumulation of inflammatory exudate due to the roughening of the pleural surface, and friction occurs. They roughens and the friction occurs between the pleural surface. So between the two layers, due to the friction, it is considered as pleural rub. This friction is called pleural rub, and it can be heard with the stethoscope on the surface of chest during when you place the stet on the surface of the chest during inspiration and expiration. So you can hear clearly pleural rub if there is any friction between the parietal and visceral pleura. Next, moving on to the abnormal collections inside the pleural cavity. Suppose if there is air in the pleura, it is called as pneumothorax. So here is an image of pneumothorax where air entered inside thorax. If blood accumulates, so if this is the blood, if blood accumulates, it is called as hemothorax. And if pus in the pleural cavity is termed as pyothorax. Pus collection is called as pyothorax or empyema. And serous fluid is termed as hydrothorax. So collection of the serous fluid is called as hydrothorax, otherwise called pleural effusion. So these are the different types based upon the content which is present within the pleural cavity. So starting with the pneumothorax. Pneumothorax means accumulation of air in the pleural cavity is called as pneumothorax. It can be spontaneous. So spontaneous pneumothorax, as the name indicates, in this condition the air enters the pleural cavity suddenly due to the rupture of emphysematus bullae. So emphysema is like abnormal enlargement of the alveoli and is called as emphysematus bulla, and it is characterized by the damaged alveoli or distended alveoli and exceptionally the large spaces leading to the rupture. So sudden rupture of emphysematus bulla causes spontaneous pneumothorax, and here the emphysematus bulla, that is the damaged alveoli, occurs due to the loss of elastic tissue inside the lungs, and the elastic tissue is lost because of chronic smoking. So open pneumothorax, this condition occurs due to the stab wounds. So here we can see an open pneumothorax which occurs due to the stab wounds on the thoracic wall piercing the pleura, leading the communication of air in the pleural cavity with the outside atmospheric air. So here is that atmospheric air which enters into the pleural cavity. So consequently, each time when patient inspires, when he takes air, the air is sucked into the pleural cavity, and sometimes the clothing and the layers of the thoracic wall combine to form a valve so that the air enters through the wound during inspiration. So but cannot exit throughout because of these tissues, they form the valve. So in these circumstances, air pressure builds up continuously in the pleural cavity on the wound side, which pushes the mediastinum to the healthy side. So the mediastinum is pushed towards the healthy side. So this is called as tension pneumothorax. So I'll just say again, tension pneumothorax is due to the stab injuries. If there is any stab injury, what happens? The air, atmospheric air enters inside the pleural cavity, and the wound tissues and the clothing acts as a valve which allows the air inside, but it doesn't allow the air to go outside during inspiration. So air starts accumulating inside the pleural cavity, which is called as tension pneumothorax. And in tension pneumothorax, we see the mediastinal structures is pushed towards the healthy side, and there will be the collapse of the lung on the affected side. So the affected side, the lung collapses. So collapse of the lung on the affected side and compression of the lung on healing. So there will be the compression of the lung on healing. Moving on to hydrothorax. Hydrothorax is nothing but the pleural effusion. So normally the pleural cavity contains 5 to 10 ml of clear serous fluid. So normally if you see the amount of fluid, pleural fluid, serous fluid present between the visceral and parietal layer is 5 to 10 ml. And this fluid lubricates the pleural surfaces to allow their smooth movements without any friction. The excessive accumulation, suppose instead of 5 to 10 ml, it is beyond 10 ml. Excessive accumulation of fluid in the pleural cavity is called as pleural effusion or hydrothorax. It usually occurs due to the inflammation of the pleura. So the pleural effusion leads to decreased expansion of the lung on each side of the effusion. So there will be a decrease, the lung won't be able to expand here. So because of the collection of the fluid, and also clinically it can be detected with the decreased breath sounds and dullness on percussion at the site of effusion. So if you do percussion, tapping, you can feel the dullness at the site of collection of fluid. The next clinical association is thoracocentesis, which is otherwise called pleural tapping of the pleural fluid. So it is the procedure by which the excess fluid is aspirated from the pleural cavity. It is performed with the patient in sitting position. So the patient is made to sit. Usually the needle is inserted in the 6th intercostal space in the mid-axillary line. So along the mid-axillary line, you will insert the needle at the 6th intercostal space, and the needle is inserted in the lower part of the 6th intercostal space, that is along the upper border of the 7th rib, to avoid injury of vein structures, that is intercostal nerve, intercostal artery and intercostal vein. So to avoid injury of this neurovascular bundle, the needle passes in succession through the skin, superficial fascia, then it pierces the serratus anterior muscle, intercostal muscles, endothoracic fascia and parietal pleura to reach the pleural cavity. So this is how we do the thoracocentesis or pleural tap. So this completes the anatomy of the pleura along with the clinical aspect. Thank you.